Last but not least, I'd love to introduce our speaker tonight. Dr. Mayoor Patel is renowned dentist and owner of the Craniofacial Pain and Dental Sleep Center in Georgia. He has extensive certifications in dental sleep medicine, orofacial pain, and embodies a rare blend of hands-on clinical experience and academic prowess. He has written the book on dental sleep medicine. He is an international speaker, and he's coming tonight to share his experience with you. As you know, please keep your chat to the chat and your question and answers to the question and answers. We'll do our best to catch all of them, but we were going to promptly end at 6 p.m. Pacific Standard Time, 8 p.m. Central, and 9 p.m. Eastern. Dr. Patel, thank you so much for being here tonight. Is there anything you'd like to say as you kick us off?
No, Chad, I appreciate that. Thank you and your team for actually making this happen and pushing me to get you guys a date. I apologize. I dropped the ball in the July one, I think it was. But it's a pleasure to be here. It's a pleasure to talk about a wonderful topic. I will try and keep this engaging as much as possible. As Chad mentioned, if you have any questions, just write it in the chat box and he will disturb me when appropriate, and I will answer your questions. And I'll leave some time at the end as well to discuss anything pertaining to the topic that we're going to discuss. Even though the topic starts with when M.A.D devices fail, tips to success, I will also bring up some other things that I want you to be aware of. In about a 45-minute webinar, it's very difficult to bring some of the key things I think you need to have. But I'm going to hit the high points to at least get you to think about it and, maybe encourage you to read a book, read the textbook that we wrote. There's a lot of stuff in there, but there's a lot of other resources as well as far as getting information. So let's see here. Okay. So when things fail, what do you do, right? So many years ago, I was asked to give a talk. It's very similar to this. So I basically went back and I looked at some of the comments that were provided, and I decided to kind of gear this talk pertain to it. So I'm going to pull like kind of the top 4 or 5 things that I think people will consider as failure. And I'm going to try and clarify what this might look like and maybe give you some tips on what you can do to try and rectify it. So snoring being the biggest one. If you think about it, when patients come in, the reason they come in is because they snore. And ultimately, the solution they want is to stop snoring. So we'll talk about snoring. There are instances, and I'm on a bunch of different chat rooms and email chains where people say, well, I gave a device and the AHI got worse, from baseline. And I think you all may have experienced this if you've done this long enough. So we'll talk about that as well. But the third mostly would be the one about a patient gets a device, he's not snoring, but still comes in complaining of being fatigued or tired, which is maybe one of the chief complaints. And, as dentists, we want to try and fix the problem. And we'll talk about some of the issues that we do, which may be a good thing, or maybe things we should be a little bit more aware of. Last but not least, and this jaw pain, I'm not going to just leave it to jaw pain, but I want to actually broaden the horizon and talk about other related pain pertaining to wearing an oral appliance, which a dentist may consider as failure to treatment. All right, so when we talk about snoring, where should we start? Well, logic dictates maybe additional titration is necessary. For instance, and there's different philosophies and schools of thought out there. Some doctors like to take their bite, say, edge to edge, and the patient leaves and they're still snoring. And they go, well, I think, this is the best I can do, because they're afraid to advance the mandible from a mere standpoint if complications were to arise. So I can understand where they're coming from. Another situation might be where you might take a 60% protrusion bite and you still have snoring, right? So additional titration will be the first thing to consider. But let's be also aware that the fact that snoring is not just tongue-based. Snoring can also be nasopharyngeal based, or the nasal passages themselves. So we need to be in a position to have at least the nasal passages evaluated if, after going back and forth, you've titrated the device and there's not much of an impact, or there's a slight reduction, but you can't seem to address the chief complaints, then maybe it's time for a consultation with the ear, nose, and throat to look at the nasopharynx, in particular look at the nasal passages and see, is this something that can be explained to at least minimize or eliminate snoring, independent of the fact that you've moved the jaw forward to try and open up the airway. I think now that we're touching on snoring, I just had a flashback. I do want to put this out and make you all aware of. As a dentist, you do not treat people for snoring until a sleep study has been performed to demonstrate whether they do or don't have apnea. If they have apnea, I tell my patient, great news, because insurance companies will pay for it. If they don't have apnea, but they have snoring and the test comes back negative for apnea, I'm like, bad news, you're going to pay out of your pocket. So people won't fight you when you say, I'm not going to treat the snoring until I know exactly what you have. And do keep that in the back of your mind. We do not treat snoring until we've ruled out obstructive sleep apnea. All right. So just hit me. I just want to make sure I make that clear. I'll get patients say, I snore some nights. I'm like, all right, well, that doesn't make sense. Why is it some nights you snore and some nights you don't snore? Well, the digger you deep, you'll find that those nights that they snore, alcohol may be on board, or some form of a muscle relaxant if they have lower back pain and things of that sort, and therefore complaining that the device is not working. So I make this clear: alcohol, those nights you don't count. If you take anything that's going to increase more loss of muscle tone, then those nights we don't consider. So we need to take that into consideration and take that history. All right. Now, failure in sleep, also in the sense of worsening of AGI, can also be the same things we talked about when it comes to snoring. All right. Additional titration may be necessary. Evaluation of nasal passages. Is it possible that there's still some form of nasal resistance occurring, leading to some esophageal negative pressure that still causes collapsibility? All right. So we want to make sure that if there's worsening that's taking place, is it that all things have been addressed? The one I find more commonly that happens is patients will get a test done, and the night of the test, they've had some cocktails, and the results get read, and you look at baseline and you look at post therapy, and you go, man, this doesn't make sense, right? I will say that worsening can happen, but more so than not, it does not happen as often. There's got to be an explanation for it. Now, if you find that titrating from a posterior anterior direction, or what we call AP direction, doesn't make much of an impact, then start adding vertical. Vertical seems to be that's the second reason in some instances that can actually improve airway. Now, this is extremely anecdotal, what I'm going to share next, but this is from Dr. Bailey's book. He makes a comment that if a patient has a large neck and is apneic, start off with more vertical, okay? And the rest of the population may be considered more protrusion. And clinically, I see that that does work. Now, there's no papers published to demonstrate this, but from a clinical standpoint, if you have someone that has a very large neck and has apnea, maybe start by being a little bit aggressive up front with vertical. So just keep in the back of your mind that these are some of those hacks or tricks. There have been instances where we've had situations where there was worsening of the AHI. One other time that I want you to be very mindful is when you have an older sleep study and you happen to give a device and you get a new study and you see, wow, apnea got worse. The question you may want to ask is it possible that the baseline as of today, maybe the number is much more than the one that you're working off of, all right? So that's something to keep in the back of your mind as well. And the other thing that you should also take in consideration is the type of testing that was done. Now, in today's world, most of it is ambulatory, and we're okay with it. But when you compare results, you want to have the same technology versus the same technology. I've run into situations where I've used a specific brand, or a patient came in with a specific testing done, and I use a different brand, and I look at the two numbers and it just doesn't tally up. But when I get a baseline on them using the technology I use, I may find that the numbers were much worse, and therefore the outcome that they're presenting with is actually successful. All right, so take that into consideration. If there's worsening, try and make sure you identify all the elements that could probably explain this. Now, fatigue and tide is just as important. Once again, the three basic things. Additional titration to see if you can improve it. There comes a point that there's only so much titration one can give. Nasal passage gets evaluated, nothing wrong with the nose. They do not consume alcohol when they go to bed, and they're not taking any muscle relaxants to explain the fatigue and tiredness. So there's 2 to 3 other things that we should take in mind. And I'm going to try to explain this by using my hands here. So say you have a timeline, right? And the person has a couple of medical conditions on it, and they present to the sleep physician and they come in with complaints of, say, snoring and fatigue. Now, as a result of coming in here, a test gets performed and it's determined that the person has apnea. But on this timeline, like I said, there are multiple other sleep comorbidities. Maybe the first being apnea, maybe they have PLMs, and maybe they have a history of spontaneous arousals. But you don't see the PLMs when the study gets done, if it was an in-lab study done, for example, because the apnea kept on waking the person up, that you never picked up significant amount of PLMs to consider it as a variable that's caused the brain to awaken. So now the apnea gets managed, snoring improves, a sleep test gets performed or in-lab test gets performed, and it demonstrates that there's adequate control, but yet the patient's fatigued. So now what you're going to look for is other things that can cause arousals, right? Periodic limb movements being one, restless leg being the other, and then there's also something called spontaneous arousals. In From a dental standpoint, if you titrate the device and you've got some of the subjective complaints under control, objectively they've been measured and it's demonstrated that things are appropriate, this is when you deflect the patient back to the physician. This is a medical condition that needs to be looked at. A lot of times what physicians will do is if a home study demonstrates adequate control, but yet the symptoms, the patients are typically placed in the lab with the device in the mouth to quantify it. And you get much better and accurate outcomes. And what we found in our years is other modalities start picking up. Spontaneous arousal being one, as an example. PLMs now get identified that never were identified initially. You manage those conditions, fatigue improves, because any of these things, whether it's preauricular movements, restless leg, or spontaneous arousals, is an arousal, just like apnea is arousal. And the arousal will lead to fragmentation of sleep that will give these patients signs and symptoms of being fatigued and tired. So just keep it in the back of your mind as well. From a jaw standpoint, I want to kind of overshoot this a little bit because you get other things that a dentist may consider as negative outcomes when it comes to using oral appliances. One being a bite change, right? Others are joint sounds that now occur that never occurred before. Maybe open contacts becomes a problem. Jaw pain, of course, being the one that a lot of patients will discourage continuation with treatment. Tooth or dental pain of some sort, loose teeth, right? Dry mouth. So let's just spend some time talking about this. If you pan the literature and they talk about reportedly temporary side effects associated with oral appliance therapy, you can see what the range looks like, right? It's pretty broad. But if you break that range down and you see, okay, what's the most common things that present themselves in these papers? These are the things listed on the slide. So I'm just going to handpick some of these things that I feel that are pretty more common and kind of spend some time talking about it so you can kind of be brought up to speed as far as what to do in these situations. The biggest one is probably bite change, right? And we've seen this if you've done this long enough. I'll give you an example or a story of one that just happened to me today when I get through with these slide sets, through this section anyway. So this individual comes in, picks up a Herbst appliance, or back then a Suet appliance. And as you can see, the date that's stamped, it was in 2011. So April 2011, this was the day of delivery. November 2011, he shows up, and this is what has happened to him. Now, the interesting thing with this patient, he did not know he had a change in bite. As far as he was concerned, he was sleeping well, bed partner was happy, he was eating well, he was talking. There's no really complications he felt he had. But this was brought to his attention by his hygienist that something's not right. So, of course, they get referred back into the practice. When questioning, you determine that this individual was not doing those morning activities that were shared that he needed to do to minimize bite changes from occurring. So now we're in this little dilemma. April was the delivery. He's not too sure when this change occurred because now it's November and we see this clinically. So we did a few things and we worked on him. And what we did is we gave him bite tabs. I'll talk about bite tabs in a second. I like bite tabs over most of the things on the market. And I showed him how to use his bite tabs, which is something he should have done every day anyway. So a month later, his bite regresses to what we see in the middle set of pictures. And by January, most of it's back. Now, you can reverse some of these situations if it's within a very short period of time. If you look at him again and you kind of follow this guy for a period of time, you can kind of sense that now that he's doing his exercise, he's pretty stable, right? I've not seen him since 2015, so I don't know where he is presently. But once they do what they need to do, they can maintain a decent bite. There will be slight changes that may occur, but that's something that they can just deal with. And like I said, the issue was not him. The issue was more his dental hygienist. Right, so this is what you run into in some cases. You have March 2020, bite was decent. May 2021, we've got to change. Now, we also make these little positions to show these patients that if they've done their homework, as long as they put this little aligner in and they fit it, everything's good. Well, this patient kept on using the aligner, but never checked. They would put it in, bite into it, said, yeah, it fits, and off they went. And enough time had lapsed. So with these aligners, that's an index of their bite the day of delivery. So they know where their bite should be. And what I asked them to do, I had them use bite taps to reestablish the bite. Basically, a piece of wafer, and I'll show you where you can get them from. Stick it between your teeth, retrude the jaw back, bite down into it for about 20 seconds, do it about 3 times. Your bite comes back. I like to make them these little aligners. I say, hey, put that in your mouth. Make sure that you fit that. As long as you fit that, you've done your homework. So even though you give them the tools and more, you'll still have patients that just don't comply. So do not be frustrated. It's in an informed consent, but I do reiterate this point over and over again when they come in for their follow-ups. So the question in the field is what happened, right? There's a school of thought that says it's edema that happens because the jaw is held forward, so the synovial fluid accumulates in the joint space, so therefore the next point they can't get their bite back. And there's a school of thought that says, no, the reason why this bite change happens is because of the lateral pterygoid shortening. Frankly, it is the lateral pterygoid shortening. If you ever had fluid in a joint, it would not revert back by using a bite tab in a minute. Okay, fluid in joint takes a long time to get out. So it's not edema that actually occurs. It's actually shortening of the lateral pterygoid, because when you use these bite tabs, you actually force the lateral pterygoid to establish its resting length. And within a minute, it's back to where it is, bites back, off you go. So we'll talk about that. Now, there's many different gadgets, tools, things out there that one could use. The one on the far left used to be called, AM position, I believe. Forgive me, it's been a minute, but it's no longer available. You have the AM aligners that you could make that used to be available, but not anymore. There's some other materials that have now been manufactured to replace it. And then, of course, the last one on the right is a bite tab. Quite simple, easy to make, easy to use. So I get my bite tabs from True Function, right? It's a piece of wafer that's cut, polished, looks beautiful, goes between the teeth. Like I said, you allow the patients to retreat the jaw back, bite down onto the wafer for about 15 to 20 seconds. Do it about 3 times, it's good to go. When you pick up these bite tabs, instruction sheets do come with it, so you can just give it to the patient. If they have, poor restorations, large composites, things like this, and you're afraid they may chip it off, then get 2 bite tabs, which they typically have packages too, and place them on the most posterior molars, and that's fine too. As long as they retruding the mandible, biting down to activate the pterygoid, you will get a return of the bite. As I mentioned, I like to give them something to go home with to verify their morning positioning. So this is what I use. It comes in this kit from, once again, True Function. Put in hot water. I like to collapse the sides in to make it nice and thick. Place it in their mouth, have them bite down into it. So we have an index of where the bite is today at day of delivery, and they can use that every day to make sure that they've done their due diligence. Right. So there's a lot of things that one could provide our patients to try and minimize negative effects from occurring. Right. Cleaning that product is just cold water. Right. So basically, I say rinse it in cold water when you're done with it, because we use hot water to mold it. If they ever come in at a 6-month and 1 year, 2 year, 4 year follow-up and they've lost it, misplaced it, I will remake it because I want them to have it. If they had a bite change, for instance, and they weren't compliant, and we now give them bite tabs to do on the hour for the next several weeks, whatever new bite they now establish, I will re-index them at their bite, because this is their new now default bite that they need to return to the next morning. So on that note, I will give you this story here. There are other milled devices that you can get also from various labs. I know True Function makes them as well, which basically indexes their bite at their habitual position, so they can wear that while they're showering in the mornings to establish that return of their bite. We had a gentleman today come in who had a tap appliance, beautiful appliance, fabricated, this is where he gets interested, by a local ear, nose, and throat doctor a couple of years ago. A year and a half ago, he had a change in bite that occurred. And when he followed up with the ear, nose, and throat, he's like, well, all you got to do is just push your jaw back and you'll be fine. So anyway, he gets referred and comes in this morning, or this morning. Now, he had an AM aligner fabricated, which was interesting. So I looked at his bite. He was, must have been class 1, and he's class 3 as of today. So I put the AM aligner in his mouth. And the funny thing is, he fits it. Like, you fit your AM aligner, but this AM aligner was made the day of delivery. So what went wrong? So he wasn't doing his morning exercises. Probably when the assistant made that AM aligner, he bit into it, and that was indexed as his new bite. And he felt that as long as he wore that every morning, his bite would return. So we'll see what happens with him. We took some baseline pictures. I showed him how to use his bite tabs. I'll see him in 4 weeks. Just do it as much as he can throughout the day. And I'm hoping to hopefully get some of it back. But I was very optimistic that, look, a year and a half of a change in bite is pretty difficult to do, but let's see what plays out. So even when you make these AM aligners, you want to verify that it's made correctly, that they were biting on their posterior teeth. Typically, when an assistant does it, not to blame the assistants, my assistant makes it all the time, but she makes me check it. Sometimes when you put something in someone's mouth, they have a tendency to want to bite forward, to bite into it, and that's when it gets indexed. So their assurance every morning when they place it is it looks fine. So just keep it in the back of your mind. Go ahead, chat.
Yeah, we had actually offered for everyone to submit questions on registration, and we had one that was really relevant to this. And the question is, what exercises are an adjunct to the morning repositioner?
Yeah. Yeah.
I think a friend of mine calls it jaw yoga, right? So
Raw yoga, there's so many different things out there, but to that point, so I'll give you what I do is basically those wafers that I talked about. These guys right here, I just give them out like candy. Okay. I want them to use this, get your bite back. I find that it's very effective. If you go back to the history of this product, it's actually invented by Dr. Keith Thornton. And back in the day when you got a tap appliance, these devices, these wafers came with it. But then he moved to those AM aligners, which is fine as well. What I find that's difficult with them is when patients place it, they just bite into it. They don't retrude their jaw into it. So I feel like I didn't get as much success with it, but I would still make it. So I would still make that product only so that they had a point of reference. Other things you can do is just take your palm, your arm, just push back, okay, on your chin and bite down into your bite and hold that for about 20 seconds. Do it about 3 times. Hubba bubba gum, something that's very dense, where it takes a lot of effort to chew, can also release the lateral pterygoid. So there's many different tools. What you just got to picture is what you need to do. If the jaw is held forward, this lateral pterygoid is contracting. What you got to do is find a method or a metric to actually bring it back to its resting length so the condyle seats. So whatever method that might be, it works, right? So, but you got to plant that seed that this is a must with oral appliance therapy.
yeah, that's so great. But we do have another question. It's not sequitur, it's non sequitur, but I figured it's a good point to mention it. Seth, she asked, where can I find additional resources for my path into sleep dentistry, and where can I get your textbook? So I will just take that real quick. Dr. Patel and I are actually teaching a course in October on how to level up, really start your journey in sleep, whether you're going from 0 to 1 or from a couple years and you're looking to go beyond that. So we'll be putting that link in the chat in a moment. And I will put the link to your textbook in Amazon in the
That's
chat.
fine.
Is that the best place to go, or is there a different
Oh,
one?
Springer. Either one of those two sources.
Okay, cool.
Yeah.
So we got that question. I think we're good on questions. Don't
No
forget,
worries.
guys, questions in the question answer. We'll try and get to all of them we can.
Cool. So the other thing I want you to be aware of is myalgia. Now, myalgia is interesting. It comes in many forms and fashions, right? So what happens to these patients? They wear a device, and at some point they may develop musculoskeletal pain. Pain is what's going to deter them from wearing the device, and they're going to come in complaining. So there's a couple of criteria that one needs to meet, and these are the criteria one should meet to be able to say you have myalgia. Basically, what it boils down to be able to replicate the pain. So if you were to palpate the area with this tenderness and this pain associated with it, as long as the pain is confined to the area you're palpating, we call that myalgia. All right, patients may say it's a dull, aching inquality. Typically, it only hurts more when the jaw is in function, such as eating, chewing, or opening the mouth in some instances. So these are things to be able to try and identify what is it that I'm dealing with. And I wanted to say the pain has to be localized to the area you palpate, only because there is another thing called myofascial pain. I've seen this happen on rare instances, especially when someone's stressed and has been wearing an oral appliance. There's just a lot happening in their life. They'll come in with complaints of what looks like pain, but it's not from the area where they think the pain is. And this would be myofascial pain. I'll spend a little bit of time explaining a little bit better. The difference between myalgia and myofascial pain, by definition, it's pain in a muscle structure. However, in myofascial pain, there's two types. When I palpate, either the pain refers away from where I'm palpating, but within the muscle itself, or I palpate and the pain goes elsewhere. And it's this pain that goes elsewhere that I want to talk about, because we've had patients wear a device and they come and say, I have a toothache, doctor, after wearing your device. Oh, shucks, you didn't have a toothache when before you got the device. All of a sudden now, within 4 weeks of wearing a device, you got a toothache. So as dentists, guess what we would probably do? We'll check the tooth, which we should, right? We may hollow out the appliance where it's touching the tooth, thinking maybe it's too much pressure on the tooth. But maybe you have to ask the question, it's very unlikely to get a toothache by wearing an oral appliance, especially when you've checked the dentition, but you're not going to put a device in an unhealthy dentition. So what's more common is myofascial pain that refers to teeth. So as you can see in these illustrations, for instance, I'll use the cartoon on the right. Where the T's are, those are what we call trigger points, right? So these areas, if I were to palpate, yes, it will produce pain in that region, but it will refer away from the region. And the master is notorious for referring into the posterior, upper, and lower teeth, right? I just want you to be aware that the temporalis itself can have trigger points, and it can refer just to the upper teeth. So typically, the anterior fibers will be more of the central lateral canine area. The middle fibers maybe the premolar, molar area, and the posterior fibers definitely the molar areas, right? So if I can't find a reason to explain their tooth pain, I'm going to go to these muscles. I'm going to palpate. Now, when you palpate, it's not just put pressure and hold. Just press once and say, all right, does it hurt? Does it not hurt? You may have to stick around for about 10 seconds. So I apply about 2 pounds of pressure. I hold it in the area, and it's okay. How's your tooth doing? No pain, no pain. Oh my God, my tooth got worse. My tooth pain's getting worse. Great. Now we know where it's coming from. It's not tooth at this point. It's a trigger point, maybe in the muscle. And like I said, in my experience, I've seen this with patients wearing an oral appliance, which has been fine for apnea, but there's just a lot more happening in their life. Divorce, got fired from their job, things of that sort, where they're now clamping on the device much more excessively. And as a result, now they're developing myofascial pain. You will also run into scenarios where you get joint pain. The more common reasons for the joint pain is either you didn't screen them prior to bringing the oral appliance in, you stuck them with the device, and as a result of the device, now they've got a flare-up in the joint pain, or you are allowing these patients to self-titrate these devices at home. And when I mean by titrate, advance it. And as a result, they kind of mucked up the way to do it. Maybe they overdid one side or underdid the other side. As a response, you now have condyles not moving at the same rate. Your one may be going more forward than the other, and things of that sort that may, in some instances, cause inflammatory process. With joint pain, if you're going to give it a diagnosis, whether it be capsulitis or synovitis, you want to be able to reproduce the pain. So in this instance right here, you'll palpate the joint and say, okay, does it elicit the pain that they're complaining of? So look at this example here. Day of delivery, this is where this individual's habitual bite is, right? So you can see where his midlines are. He gets a device, he takes off, he shows up at some point down the road, and you can see his midline's off. So as a result of midline being off, his right condyle was slightly more distalized than the left condyle. And as a response to it, he was having right-sided jaw pain. So once we corrected his midline, put in some anti-inflammatories for a few days, the pain went away, right? So here's simple little troubleshooting hacks that one can pay attention to. They can explain some of this. Tooth pain can be pain on awakening, and this can be depending on the type of device you might use. Tooth sensitivity biting, that's not uncommon initially. It lasts up to about 30 minutes, but over time, this does get better. When you have the tooth sensitivity on biting, either the occlusion's heavy on that side, which is one reason for it, or you'll see that if it's infrequent, some nights is there, some nights it's not there. It could be just merely the fact that they're clamping excessively those evenings, leading to some tooth sensitivity. If it's an ongoing issue, and we talk about more posterior teeth, then what I may do is modify the sleep appliance and add like a discluding element where there's a little bit of a rise in the front to disclude the posteriors. So the act of clamping and clenching occurs. The airway is held open, but because they can't power up, because posterior teeth are not now in the loop, you don't see this as being a big problem in the long run. So sometimes modification devices are necessary to take the pressure off these teeth, right? Other cause of tooth pain can be maybe if you took impressions and they were poured up, there's some wear on the stone, or your distorted impression. So a couple of things there. If it's wear on a stone, you can adjust the area of concern. Typically, I would take care of it if it's just one tooth or two teeth. But if it's multiple teeth that they complain on, I would suggest just remaking the device. It's probably distorted to the point that just trying to take a burr and get it more comfortable is just not practical. Other causes is, like I said, clenching, poor posterior support, or no posterior support. So once again, something to keep in the back of your mind. Now, I will say that if you're going to adjust these devices, you want to use something called the bull rule, right? Basically means on the upper aspect of your sleep appliance, only adjust the buccal portion of the upper teeth. And if there's ever sensitivity or discomfort of the teeth on the lower arch, then adjust the lower wall of the lower arch. Okay, so buccal wall of the upper, lingual wall of the lower, because that's typically areas where the pressure is engaged when they're wearing these devices, and leave the other wall intact so it passively just supports the tooth. What you're trying to do is minimize teeth movement also within the parameters of these devices as best as possible. You will run into dry mouth. Most common cause is if there's too much vertical and they can't get a lip seal, they're going to mouth breathe. And as a result of it, they're going to have a dry mouth, right? Another time they may have dry mouth issues is nasal. So if they have nasal obstructions and this was not looked into in the front end, now you put a device in the mouth, and as a result, you've got that vertical component. They have mouth breathers to start off with because the nose doesn't work. You're going to have a dry mouth. And then be mindful. Some of these elderly patients are taking medications that will dry them out. So we need to take all this into consideration. If I can't modify the device because I need the device to be where it needs to be for them to be therapeutic or whatever the situation might be, I like to use Xerostone. You get this off Amazon. It's very natural. Its pH is more alkaline. And I basically have them take the moisturizer, so the substitute gel, and just coat their cheeks, their lips, upper lips, a little bit of the tongue with the mouthpiece and go to bed. And it leaves a nice coating behind. It has xylitol in it. So therefore, it just gives them enough of a lubricant so they don't have the dryness feeling. All right, so there are things that one could use to try and minimize some of this. I do run into mobility, especially in the anterior lower teeth, more than the upper teeth. Typically what happens is if you look at the mechanics, right? So you have the upper aspect on the upper, the lower on the lower, and the person goes to bed. Now, the maxilla is fixed to the skull. So the maxilla is not going away, but the mandible wants to fall back. So if the mandible wants to fall back, the teeth are going this direction. The device is holding it. So you're going to get pressure on those teeth, on the lingual wall. Right? So as a result, the jaw wants to fall back. You got the lingual wall of the sleep appliance. You're going to get pressure on it. And over time, you might get mobility. So in that instance, what I do is I use the bull rule and I just reduce the lingual wall of the lower. So therefore, the jaw wants to fall back. They still have passive contact on the buccal aspect, but there's no pressure being exerted on the tooth as a result of it. And in this case, more the lower anterior teeth. Do check for mobility. All right. So when you see them at your recall, just make sure the anterior teeth are not as mobile. If they are, then do consider this rule. I also suggest that before you insert the device, just see what the baseline mobility looks like before you proceed. Salivation does unfortunately fall under the side effect category, but frankly, it's not really a side effect. It's just an effect, okay? And it's the fact that there's something in your mouth and you're going to drool for a little bit. This does go away with time. So a couple of things you can do is suggest they use a towel for the first week or two. There's been a few instances where I've asked patients to use Benadryl just to dry them up so they can get acclimated with the device, so they can get past this little hurdle. So moving to the future, salivation is not a problem. So these are a few things that you can take into consideration when trying to improve the outcome so it's not a failure of care. The open contacts, the reason for open contacts, and there's a lot of philosophies out there. This is my take, and this is what I do. When you have great embrasures, so let's look at this example, a great occlusal embrasure. When the lab makes the device, they make it to cover the teeth, right? So you're going to have acrylic that's going to basically web interproximally from the occlusal aspect into the embrasures. Now, when you have, like, say, a dorsal appliance is flat on flat, and they're wearing it and they clenching or clamping down on it as a result of other things, well, you got this wedge-like effect. So when they clamp down, you're wedging between the teeth, and over time, you're going to open up that contact. So what I do is when someone has very prominent occlusal embrasures, I just tell the lab, hey, just block them. If they block them when they fabricate the device, there's no acrylic that's going to leach into proximally. So there's no pounding of forces that's going to cause any open contact. But I do want the embrasure and the buccal lingual to be present. And the reason for that is I need the retention. Okay, these devices need to snap into place. If the retention is poor, when the jaw is being pulled forward, they're going to fall out of the device. It's just going to be counterproductive. So embrasures in the buccal lingual, keep. Embrasure in the occlusal surface at the dominant, remove. If you had a device that came back and now you see there's an open contact, look at the device. If you see there's an occlusal embrasure, just take it off with a burr. And for the most part, it may close back down, but it won't worsen it any further. Right? So these are a few things you can take in consideration. So let's look at this example right here. Day of delivery, where's this device? Shows up, has this. Wow. So he's doing his exercises. He's telling me he's doing everything like he should. So what exactly happened, right? So what may have happened with this guy? Well, let's look at a couple things. So in a healthy joint, you have a disc, right? So if you look at the far left picture, at 12 o'clock, you got the big blue mass, which is the posterior band of your disc. And when you open your mouth, the disc goes down the articulating eminence along with the condyle. Everybody's happy. And you got a video to kind of show you what that looks like, right? This is healthy. This is normal. This is life. But what happens is out there, you have patients that have a disc that's slightly anterior displaced, right? And when they open, they hear a click. Right? Not a contraindication, just something to be mindful that, hey, listen, you've got a clicking joint. I'm going to put the sleep appliance in your mouth. But today, it seems like in your mouth, everything's touching. You're occluding on both sides posteriorly. And they may come down at 6 months, a year and a half later, and go, man, my left side doesn't touch. Oh, yeah, but your left side had a clicking joint. Do you click? No, my clicking's gone away. Oh, wonderful. The disc must have reduced. The disc must have gone back in place. And as a result, it's now occupying space. So if it's occupying space, you're going to have a unilateral posterior open bite, right? So these are things that you want to kind of be aware of when you work your patients up. If they have any of these pre-existing conditions, prep them on what may happen if they wear the oral appliance. Then you have this situation here where a patient comes in, you take your range of motion, there's no deflection, there's no limited opening. But what happened is you didn't ask a question. Did you ever have a history of a clicking, popping joint in the past? And they'll ponder, they go, now that you mentioned, yeah, my jaw used to click, but today it doesn't click. You don't have any deflection suggesting the disc is out. You got decent range of motion. So you're like, well, you must be healthy until you put an oral appliance in, and then this happens. A posterior open bite happens, right? And then you're back to the drawing board. What went wrong? Now, if you think it through, if you have a bilateral posterior open bite, it's because of the lateral pterygoid. Jaw goes forward, you didn't do your morning exercises, jaw doesn't want to go back. It's not like one muscle goes back and the other doesn't, right? So keep in mind. So when it's a bilateral posterior open bite, I'm thinking muscle. When it's a unilateral posterior open bite, I'm thinking internal derangement of some sort, some form of internal component here. So with the unilateral posterior open bite, what happens is at baseline, they can open, close, and everything, and that disc was anteriorly displaced, but there was no evidence of it. The evidence would have been if you asked the question, was there ever a history of clicking, popping? But because they're wearing a mandibular advancement device, right, a sleep apnea device, it opens up the joint space, takes the condyle forward, and if the joint space is open adequate enough, it's possible the disc pops back in. So I want you to look at these little illustrations. In the acute stages of someone having a closed lock, there's deflection to the affected side, and they can't open as much, right? And if you looked at it, the condyles don't move much because the disc is anterior to it. But if time goes on and treatments are rendered, you'll start finding that the range of motion improves. And guess what? The deflection is not as evident as the first picture, where it's significant to the left. Now, by picture number 4, it's pretty straight line, and they can go down the evidence. So that my range of motion looks good because the progression of a displacement without reduction over time is exactly this. They may look more normal somewhere down the road. But if you took them with picture number 4 and thought they were just healthy joints and stuck an appliance in the mouth, now a couple of things can happen. My jaw starts popping. I had no popping until I got your sleep appliance, and now I'm popping again. What happened probably is if you took a history and they had a disc displacement in the past that had a clicking joint that stopped clicking, what you just did is set up the stage to allow the disc to reduce again, which is a good thing in my opinion, but from a patient perspective, it's a noisy joint. And that's where the popping is coming from. So that asking that question is extremely critical to try and minimize this from actually occurring, right? So keep that back in your mind. Your disc was out. I put you in a device. I open up that joint space. You can see the difference between joint space picture on the left versus the picture on the right when the device is in your mouth, and boom, disc happens to go back in, stay in, right? So this is where you get that unilateral posterior open bite. Let's look at this case right here where this lovely lady was diagnosed with moderate obstructive sleep apnea. She's got this M.A.D device back in the day. She was self-adjusting device once a week. 3 weeks later, she calls the office. She goes, I'm in pain. So we bring her in. She goes, man, my pain's right here. So it's the massive muscle. She describes it as a dull pain on my left. We palpate the muscle, we're able to provoke it. And the pain lasts for a couple of hours after waking, but it gets better as the day goes on. So we start, let's look at your bite. This was a habitual bite. This is a bite with the appliance in. What went wrong? Over titrate maybe one side. And so correcting it and bringing it back to midline, I had to take a break from it. 3 weeks later, brought her back in, no more pain on the left, she sleeps better, and she went ahead and advanced it 2 additional millimeters to try and get better outcomes. All right, so these are things that you just need to troubleshoot chairside when you have these patients. Here's an example of a lady that comes in, bicuspid extraction. She's a significant bruxistic clencher. She's got a late opening click on the right side. Palpation-wise, nothing is tended to palpation, so she's healthy as far as I'm concerned. Opens to 47, lateral excursions are 15, 15, protrudes about 7. Really nothing happened. There's a little bit of deviation to the right on opening. All right, healthy lady. So this is a baseline. She's moderate apneic, fantastic, significant desaturation that we don't take into consideration at 77%. Stick her with this because of that history of bruxing that I said. I was taking a precaution. I said, I'm going to put you in a device. I'll put an anterior discluding element so your posterior teeth don't touch. I'll titrate you forward. Everybody should be happy. Well, this was her. And this is her after. So you can see the difference here, right? So something's changed. She's opening better, but a few things kind of went wacko on us. So we got to measure to say, all right, are we going to bail on treatment? Is treatment working for you? Well, we get the apnea study report, 4.9. Anything less than 5 is considered not a problem. She's not complaining of any symptoms, so she's happy. Therapy is working, but we've got this little hiccup. So what do you think happened? Do you think something reduced? Do you think something came out? Do you think there's a spasm on the left side? chat. The first three people that type in either 1, 2, or 3, just share with me what their thoughts are, and then we'll give you the answer.
We've got Jesse Caldwell says number 2, disc on the right reduced. What about you? What else you guys think? This is a can you go back one slide for us, Doc? All right, we've got a complicated case. We've got objective improvement with the sleep study. Patient's happy. Therapy seems to be working. Any other guesses for Doc?
So choice of 1, the left side reduced, 2, the right side reduced, or 3, there's a spasm on the left.
We have 3. We have so far 4 responses, all agreeing to number 2.
Perfect. So they were listening. Yes, number 2 is exactly what happened. So disc on the right side reduced. The giveaway is we look at the history. So when you compare baseline to what happened, there's no clicking, there's no deviation, giveaway, right? Slight open bite on the right side totally makes sense. So in her case, it was a good thing. Disc went back in. Thankfully, I had educated and prepped her because of a previous history of a clicking joint. So it wasn't an issue. But this is what I'm trying to plant the seed that if you don't do your due diligence up front, and something goes wrong, then you're going to blame, they're going to blame you for it. And it's all about just educating the patient. I want to finish. Yes, sir.
How in your own words, how important is the patient education side of this? And would you say that you can reduce the perception of failure through this communication, such as setting these expectations and things beforehand?
You know what, Chad? Thank you. That's exactly what I should have led with. So let me finish this slide, and I want to definitely add lib to what Chad just said. There's a paper, it's open access. It's a great paper that talks about management of issues that may arise from oral appliance therapy. So just go to Kevin Jones Sleep Medicine. You can search for this paper, download it, keep a copy. It's pretty good. It's a lot of pages, but it's totally worth having chairside. Everybody's got opinions. I have my opinion. One of the things they put in a lot of these things is wait and watch. I don't understand why we're waiting and watching when things happen. So when you read this paper, they'll say, oh, this is the condition, blah, blah, blah. First thing, maybe wait and watch, blah, blah, blah. I don't like to wait and watch. If there's something that happens, figure it out, deal with it, move on. All right. There's only a few instances I may wait and watch. So that's my only thing about this paper. But everything else in this paper is fantastic. So do keep it as a resource. So what Chad was saying is expectations, and this is so true. So a couple of expectations. When they come in and say, Doc, I'm snoring. I got apnea. I want to fix my snoring. I plant the seed right there. Listen, buddy, I'll try my best to get your snoring under control, but you understand, you have to understand that snoring is multifactorial. And I'll go about the nose. I'll talk about all these other components, alcohol consumption, body positioning, chronic allergies. We want to have all these conversations up front. So they know going in, there's not just my device. It's my device and maybe other adjunctive therapy that needs to be done. Secondly, I might say, hey, look, we'll put you in this device. You have severe apnea, you failed CPAP, or you refuse to try CPAP. I'll do my best. But if I can't make positive outcomes because I'm more concerned about your health as a result of your condition, you may need to consider adjunctive therapy. Then I explain to them what adjunctive therapy is. We may have you do PAP therapy with the oral appliance. Well, why would I do that? Well, beautiful thing is, since you got the oral appliance, if it were to fail, by me now giving some form of intervention, such as CPAP, I don't have to be as aggressive on the PAP pressure setting because the majority of the obstructions pull forward anyway. So now just puffing in a little bit of air to get your values down. Oh yeah, that makes sense. All right, so there's a lot of things you want to put up front. Jaw pain being the other. Bite change, I use this all the time. Are you able to give me 2 minutes every morning if you commit to oral appliance therapy? Yeah, why? Because I need you to do these morning exercises so you minimize a change in bite, or you look like Jay Leno. And then I get the little chuckle and they go, yeah, I don't want that jawline. I said, but you want his money, I'm sure. Another chuckle. But they get the point that if they don't do these little things, which is housekeeping, you're going to have a problem. So yes, Chad, I do need to put that on the table up front. They need to know. They also need to know that they're going to have to get a follow-up study. Yes, you might say you're not snoring. Yes, you are feeling rested and refreshed. I don't care. But you're going to be referred back, and I do need you to get a follow-up study to just compare to make sure that your health outcomes look good, such as oxygen desaturations and things of that sort. So I do want to plant that, and they need to understand that. And the final thing is, once you get this device and we get you dialed in just right and we get it verified, I do want to see you in 6 months. You got to commit to that because you're going to get issues that may arise if I don't keep an eye on it. For example, device starts deteriorating, a bite starts changing, teeth start moving. From a layperson standpoint, you may not see this as a problem. I want to try and intercept these problems from becoming a problem. So you are going to see me in 6 months. And if in 6 months things are great, I'll see you in a year. Right. So we have an open door policy. If you're not too sure what's happening, call me. But this is the commitment in getting a device. It's not just get it and leave. We will have patients that leave state, and that's understandable. So I will give them a resource at the AADSM website. Here's other providers that do this type of care. Establish a rapport with them when you move to that city and let them take over your care. So these are things you definitely want to plant the seeds on. Oh, dogs. Love dogs. I don't know how many times we get 2-3 times a month, dogs destroy the device, right? So we plant that seed as well. Lately, and I've been using this a lot lately because I had 2 patients just the past month, airline checked luggage, don't check it in. Bags may never come back, your device never shows. So I've been suggesting they take it on the carrier, which they should, you think. But we've had patients check their luggage and it never makes the flight. So these are things that I've now started putting on the table before we go further.
I actually heard a story, and I don't remember the details, but a guy broke his appliance because his lawnmower got it. So I don't know what the situation was that got into that particular, but garbage disposal seemed much more reasonable to me. But yeah, they're all out there. We do have a couple questions. So Doc, that was fantastic, and it was really cool to hear that perspective on setting expectations. I also love that you show up with the different options for them too from different providers from ADSM. Doctors, put this on the screen, folks. We're going to get to questions in just a moment. If you are interested in the business of dental sleep medicine, Awaken Sleep has one live event per year that we do in person. The rest are virtual. And this is our Business of Dental Sleep Medicine course. We're going to be doing it in just a month or so, a month and a half in San Diego. And if you want to really dive into the business of sleep, this is the course for you. We are not going to be talking about condyles and lateral pterygoids or any of those types of things. We're going to be talking about dollars and cents and physician referrals and how to do all that kind of stuff. We do only have 5 tickets left to the event. It's a smaller event. I know some of the folks here are already registered. So, and I think we only have like 10 hotel rooms left. So make sure to get you and your team registered soon because we'll be sold out pretty soon. We'll put the link in the chat for that in a moment. And then if you are enjoying work with Dr. Patel, if you want to go to the next slide, we're going to be doing a level up in dental sleep medicine course. And we've labeled it this because it doesn't matter where you are in sleep. You could be thinking about getting into sleep for the first time. You could have tried sleep and not gotten anywhere in sleep, and now you want to restart. You could be doing a couple appliances a month and you want to do more. We're going to be touching on really a couple unique perspectives. Dr. Patel is going to be showing you really the appliance workflows, the impressions, the different appliances to use, how to take impressions, the whole gambit. And then we're going to combine that with workflows, verbiage, tips, tricks on how to get better results. And trust me, we've got practices, many of whom are on this webinar tonight, who will testify that it doesn't matter how experienced they are, they always get some value from this. And it is going to be such an honor for us to have Dr. Patel on there as well. So we've got 3 spots remaining. It's $797 for the doctor and 4 team members. Yes, that's 5 people, 7 CEs for each. Yes, it's 35 CEs for $797. You can scan that QR code if you want. I'll put the link for that in the chat in just a moment. So with that, let's get to questions. First up, we had a couple entered in the chat, or one entered in the chat. Gustavo said, in every case, how many millimeters must we go forward in our appliance? I don't know there's a set number, but what would you say how do you approach that?
There's no rule to this. I personally just do a millimeter a week. If they've already worn a device before, I might say do a millimeter every couple of days just to get to the point of therapeutic. Before the 1 millimeter rule, we used to do 0.5 millimeter. The way the millimeter showed up is when Naval back in the day showed up with their appliance, their straps 1 millimeter advancements, and people like shied away from it, like, oh my God, we can't do that, it's too much. Well, those of us that tried didn't see a negative consequence with a 0.5 millimeter or a millimeter advancement. And that's when I changed my mindset. I'm like, look, if I put CPAP on you today, you'll be 100% therapeutic if you comply with it. Then why am I dragging my feet to get you therapeutic by being afraid to advance your jaw? So I just go 1 millimeter. Now I'll have hiccups every now and then when someone says, man, I'm sorry, I'm dropping. All right, back it back. Let's just go 0.5 millimeter. Right. So there's no rule to it. If they can tolerate, do it. If not, then, slow it down.
Perfect lead into our next question. Say you set the patient 50% range of motion and want further titration to 60, 70%. What do you advise to be a good titration schedule? And I'll actually add a little piece onto that. What is your typical starting position? Because if you're doing 1 millimeter a week, you're probably not starting at 70, 80% of their
No.
ROM. So what does that
So
look like?
this is very tricky, right? There's no rule to any of this. And I hate to say this next thing, but there's no special apparatus, gizmo, whatever you may be told that you should purchase to be able to find this. Right? It's all arbitrary because everything we find is when the patient's awake and upright. When they sleep, the physiology is different. I go about 50 to 60 millimeters, and I use a George gauge, right? Every now and then I'll use matrix from Kettenbach, right?
Yep.
And there's reasons why I use one over the other. I'll go over that as well. But I need a starting point of some degree. So I want to be at least 50 to 60 millimeters. Now, I want you to think this through again from another perspective. Let's just talk about, say, a dorsal appliance. When you advance that dorsal, that screw maxes out at 6 millimeters, right? So let's just keep them back in our mind. If someone protrudes, say, 14 millimeters, so retrude, protrude, and I get a 14 millimeter, and I only take them about 5 millimeters, and they crank, and they add the 6 to the 5, we had 11 millimeters, but they could go to 14. Now I'm short 3. And if I needed them to titrate, I can't because the device is maxed out. So now I got to send the device back to the lab, reset the screws, send it back to me, put it back in the mouth. So I also take that into consideration. What device I'm going to use. If I have a lot of millimeters I can muck with, then I might be a little shy, or I might use a device that I don't have to be as aggressive if they have, say, pre-existing jaw issues. And I might start slow, but I know I have enough straps, if it's like an EMA, or whatever apparatus I might use, so I can take them to the maximum protrusion. So knowing what their range of retrusion protrusion edge is, status of their joint, how bad the apnea is, I'll take all that into consideration. So it's just more of a clinical judgment, but I'll be between 50 to 60% of protrusion of their protrusible distance is what I would like to start with. It's a lot.
Yeah.
But the more you do, the easier it becomes. But you just got to think the logic behind why you do what you do, and you build in that buffer.
Yeah. Well, and I think if I'm understanding your theme, your overarching theme is you're asking a lot of questions, and based on the answers to those questions, kind of pursuing it like an investigation, you're choosing appliances and really an approach with both your gauge methodology, whether you're using the Kettenbach gauge or the George gauge, to really determine what the best position, as well as vertical, which is why you would use that Kettenbach kit, the aerometrics, or and the appliance as well.
And the reason why the aerometrics is great is you let patients that are very like, oh my God, how is this going to work for me? That's fair. I don't know until we do it, right? So I'll pull out the Kettenbach gauge and sorry, let's generate a snore for me, chair side. They generate a snore. And I'll go through my shims. And when I hit a shim that the snoring is very nominal or non-existent, they're like, oh my God, this works. Oh, great. So now I've built in that peace of mind variable. I don't know if it's still going to work until they fall asleep, but they have assurance that we're on the right path. So that's when I will whip out the Kettenbach matrix to educate the patient and demonstrate that we can make an impact on the chief complaint, which is noise anyway, and then go from there.
Yeah, that's very, very powerful. The Kettenbach Aerometrics kit is a really, really cool kit. They've got a bunch of different gauges and stuff. If you guys have questions on it, let us know. We've got some pretty cool relationships with Kettenbach. It is a little technique sensitive, we've noticed, but it is a very cool kit. We do have one last question. It's not super relevant, so I apologize, Glenn. It's not directly related to appliances and complications, so I've been saving it. But she says, today I had a patient who claims that when he pushes on his lower first molar, his chronic neck and forehead pain goes away. Can you speak to this?
I don't know where to start. So this is a situation where you would have to work this patient up and understand what exactly are they presenting with. Is there a cervical component? Is there a history of any arthritic changes in the upper cervical spine? potentially to explain this. We do know that the trigeminal nerve and the upper cervicals do communicate in the spinal tract, so they could be that correlation there. It's a hard one to really comment on without really physically working this patient up and understanding or trying to see if there's an explanation for it. Right off the bat, I can't think of anything specific, but I think by exploring and asking appropriate questions, maybe we can get to some form of understanding of what this might be.
Got it. Cool. All right, folks. We have, man, I'm gonna try and do lightning round, all right, Dr. Patel. So you have two questions. We'll try and do them under 30 seconds. So one is hard to do in 30 seconds. I tried to ask a follow-up question in the chat, but do you work with the test appliance? I've never heard of the test appliance. I don't know if you have.
I think they may be talking about like a temporary appliance possibly, which would be a
Sure.
test
Oh,
appliance.
that's probably what it is. Yes,
Yeah,
yes.
yeah. We'll do that. Once again, skeptical patients, they're like, I don't know if it's going to work. I might make them a MyTap chair side, or I might make them the EMA nows. Let them try it for 4 to 6 weeks. If they feel like it's therapeutic, then we commit them to a permanent appliance. So yes, I definitely would use them in many instances.
Awesome. Are you doing a discounted fee for that typically?
So I charge them, I think, I don't think we can talk about numbers, so I'm not going to bring it up, but I charge them a very nominal fee.
Yep.
And then what I do is I just credit it to the permanent
Full
device if they
appliance.
decide to go down the road.
Cool. Jesse asks thoughts on a cone beam or CBCT before starting treatment with an oral appliance.
Yeah. So don't fall for the fact that you buy a CBCT to find your apneic patients. I think that's just a marketing ploy to get, I'm sure I'm going to get shot tomorrow. But anyway, I've got plenty of cases where people have big wide airways and people say, well, you need to use a CBCT to determine airway. Okay, great. Big wide airways, but the person's apneic. Well, how's that possible? And I may have someone that's a very small, skinny airway. And it's like, you got to be apneic. They get tested, nothing comes back, right? There's too many variables here. The problem with that is the person's awake. Once again, the upright physiology is different, right? When you sleep, mechanically, things change differently. But I do like the CBCT for two reasons. One, assess nasal passages and sinuses. And two, in my case, look at the health of the joints and teeth. So I will use it from that metric standpoint, but not to find apneic patients, just to make that clear.
Yeah, and Jesse actually elaborated more on evaluating the TMJ, screening TMJ,
Yes.
which is a better application.
It is.
Yeah,
It is a
and
application.
there used to be an appliance, actually, they updated their workflow that required a pre and post cone beam in the pre-titrated position, post being in their starting position for the appliance. And it was kind of interesting to see changes on the airway for that one. But I will say, if you are a dental practice who's doing cone beam and you're already getting a cone beam, you may as well get the airway, and then kind of look at it. It's a great communication tool. But, and I apologize for the sarcasm, you have to be asleep to demonstrate sleep apnea. So that's, it's a communication tool. And it can be screening. There are studies on that, but to Dr. Patel's point, like these are all kind of auxiliary benefits or bonuses for practices who already have the technology in place.
Exactly.
Yeah. Well, folks, Dr. Patel, thank you so much for joining us tonight. We actually got to all the questions that people entered in the chat. So, folks, I already posted, just so you guys know, a list of the links. I posted the study Dr. Patel referenced, his book, the course, the CE link, and the masterclass link. When you exit the webinar tonight, you'll be automatically redirected to the webpage for the survey tonight. So make sure to get your CE, take the 32.7 seconds to complete that. And if you guys have further questions, please feel free to reach out to our team. We're happy to answer them. And Dr. Patel, thank you so much for just volunteering your time tonight and really just bringing 150% to equip these folks. We really appreciate it.
Well, thank you, Chad. We'll talk soon, buddy.
Alrighty. Have a good night, everyone.
You as well, everybody. Have a good night.